Okay, now we're going to talk about fixing an inguinal hernia. We have a patient who's lying with the head facing up, the legs facing down, the patient's right and the patient's left. We're going to go through the layers of the abdominal wall just to kind of orient you. So the brown is going to be the skin. I pull that back, and underneath the skin will be subcutaneous fat. Notice the superficial epigastric vessels, which in some people require ligation. Smaller people, you can cauterize them. Larger people, it's best to tie them. Under the subcutaneous tissue is Scarpa's fascia. Now Scarpa's is, let me just show this to you before we move on. Scarpa's is a very ethereal connective tissue separation between subcutaneous fat and the external oblique aponeurosis. Some people try and sew this back together. Other people include it as a mass closure when you close the wound. And we'll talk about that. Then you get to the external oblique aponeurosis, which is functionally a tendon of the external oblique muscle, which lies out here. So aponeurosis is a tendon. In this case, it's a flat tendon. Under the external aponeurosis, when you make the incision, you see the inguinal ligament up here. This is the inguinal ligament. You see the internal ring and the cord structures coming out. This white process here is the vas deferens, right here. And then notice here the floor of the inguinal canal. We have internal oblique muscle, transversalis fascia, and many times the muscle is more rostral to the transversalis fascia, which can be found just rostral to the inguinal ligament. And then under that is the peritoneum, which I'm going to show you down here. Okay? So why don't we now do a right inguinal herniorrhaphy. Okay, so now let's fix an inguinal hernia. We're going to use the right side as the example, but before we start, we're going to talk about our landmarks. The landmarks are the anterior superior iliac spine, which you can feel easily here. To find the pubic tubercle, go to the pubis, and then work laterally until you find the lateral edge of it. That line between pubic tubercle and anterior superior iliac spine is where the inguinal ligament lies. If we want to determine where the internal ring is, it's usually half the distance between the pubic tubercle and the anterior superior iliac spine, and about a centimeter rostrally or cranially. So this should be the side of the internal ring. The external ring is just lateral to the pubic tubercle here. So inguinal ligament, internal ring, pubic tubercle, external ring. Now most people, when they make an incision, they follow the Langer's lines. It's not a straight line, but it's a curved line. And I like to go just lateral to the pubic tubercle and about a centimeter up, centimeter rostral from the inguinal ligament. So here's the inguinal ligament. I'm going to make an incision like this, curving it. So I'm going to do that now through the skin. And when you go through the skin, and I'm going to make it a little bit longer to make it easier for everybody to see. When we separate the incision, what do we see? We see the subcutaneous fat, and notice the inferior epigastric vessels, superficial epigastric vessels. Let's assume that in this case we take a cautery and we buzz it rather than ligating it. Next, we go through the subcutaneous fat, and it's relatively thick. Once we've transected the subcutaneous tissue, it's often best to put in a self-retaining clamp to pull back the skin and subcutaneous tissue, which exposes scarpous fascia. So I'm going to cut scarpous fascia, and I'm going to use the scissors to show you how thin this is. You can see how thin it is, and quite frankly, if you pull on it, oftentimes you can tear it. So it really has little strength. And now you see the external oblique aponeurosis. Now, the next maneuver is one of the most important when you're fixing a hernia, because you want to open up the external oblique aponeurosis through the external ring. If you don't, it will only separate a little bit. If you go through the external ring, it'll expose the entire inguinal canal. So to do that, you can put your finger in and either feel the external ring, and if it's a large indirect inguinal hernia, often you can put your finger in and feel the hole. And I'm going to do that now, and I can feel it here. If it's a direct inguinal hernia or a small indirect inguinal hernia, oftentimes that ring is not palpable, and you can feel it by feeling where the pubic tubercle is and going just lateral. So I can feel the ring here. I've got the ring under the forceps. I'm going to make a little hole in the external oblique aponeurosis, and then the fibers run in this direction, and usually you can just push the clamp down to the external ring. Now, I haven't opened the external ring yet, and you notice how you don't see much of the inguinal canal, but once I open that external ring, now it opens up, and what we see underneath is the inguinal canal. Okay, so now we've exposed the inguinal canal. Using a retractor, we see the internal ring where the cord is coming out. Inside the cord should be the artery to the testicle and the pampiniform plexus, the veins draining it. If you look around, you'll find the sac, which is anterior and rostral to the cord. And then somewhere in the back, you probably won't see, but you'll feel the vas deferens, and it feels like a thick cord. Now, one of the other two things you should keep in mind is the ilioinguinal nerve and the iliohypogastric nerve. Now, if you read in the textbooks, it'll say the ilioinguinal nerve is anterior to the cord structures. Well, it is 60% of the time anterior and runs in this direction. 30% of the time it's within the cord structures, and 10% of the time it's actually posterior, and it comes from lateral here. The iliohypogastric nerve is much more cranial and tends to lie about 1.5 centimeters from the internal ring and from where a direct hernia occurs and where you're going to sew your meshing. It's usually up here. And you know that supplies the skin of the anterior abdominal wall, cranial to the pubic tubercle. Ilioinguinal nerve supplies usually the skin to the lateral border of the scrotum, and much of the time the medial aspect of the thigh. You can cut the ilioinguinal nerve, but then the scrotum, or in a female the labia, is insensate. It's probably not a good idea. The genitofemoral nerve is a difficult one to find. The easiest place to find it is actually posterior to the internal ring, and it gives off a branch that goes down usually to the anterior part of the thigh and the lateral part of the thigh. Most of the time, you don't see that. So now we've exposed the inguinal canal, and what we want to do first is we want to get under the cord structures. And the easiest way to do that is, and the safest way, is to go caudal to where the cord is, find the pubic tubercle, which I can feel, and then you put your fingers in like this, in this direction. And you'll get behind the vas deferens, behind the cord, and come out here. Sometimes in a fat person, it's easy, it makes it easier if you pull the internal oblique and transversalis up a bit and take a spreader and just spread in this region. There's a potential plane there, and if you spread in this region, when you go to put your finger through, it'll come through more easily. So let's go ahead and get a Penrose drain around the cord structures. So here's the inguinal ligament, here's pubic tubercle, and we get underneath it, underneath the cord structures out here, and now we'll put the Penrose drain around it. And before you do anything after this point, you have to make 100% sure that the vas deferens is in there. And if you feel this, you'll feel it as a thick cord. Now, if I looked at this and the inguinal and the cord structure was this thick, I would say he probably does not have a hernia because this is very thin. But in this case, now it's thick, I would say there probably is a hernia there. That is a peritoneal sac. So what I do at this stage is I put the Penrose drains out to the side, and then using a scissors as a dissector, not as a cutter, as a dissector. You can put your scissors in and dissect, and another forceps here, and you separate out. And indeed, he has an indirect hernia with here's your peritoneal sac. Now you want to ligate this as high as you can. And you can do it one of two ways. You can pull this out, put it on stretch, so this part of the sac is actually posterior to the inguinal ring. It's just the internal ring. It's just when you pull on it, you can pull it out like you can pull out a finger on a glove. And there's some people who take this and twist the sac. And the idea behind twisting the sac is if there's anything in it, it pushes it down. What I like to do is open the sac. I'm going to do that here. And then you can look inside. You can actually see inside the sac. And if you want, you can put your finger in and you can feel for a femoral hernia. Remember, the iliac artery is right there. It is 4 millimeters behind the posterior wall of the inguinal canal. And if you feel the artery, the vein is going to be just medial, and then you can feel the femoral canal because of the so-called arcuate ligament that serves as the medial border of the femoral canal. And then you can take your finger this way, and you can feel the posterior inguinal floor to see if he has a direct inguinal hernia. Now, if it's a direct one, you should feel it. It doesn't really matter because you're going to cover that space with mesh anyway, so I usually don't feel for a femoral hernia. But one trick is, let's say you get into the operating room, you think the guy has an indirect inguinal hernia, and you open up the inguinal canal, and there's no sac there. So right away you should think, my God, maybe he had a femoral hernia. And in that case, you can always pull up a little of the peritoneum, even if he doesn't have a hernia. Open it up, put your finger in, and if you feel a femoral hernia, well, then you have to change your approach. But let's assume this is a straightforward indirect inguinal hernia. So you pull it up so that the base of your wound here actually is intraperitoneal peritoneum. And I like to put a purse string in from inside the sac, because then I can see every stitch and I'm sure there's no bowel in it. Other people put it in from the outside, but when you're putting it in, you have no idea what's going on inside. Or if it's a small sac, you can twist it. Now that you've seen inside there's nothing, you can twist it and put a suture ligature in, or you can just pull it up and put a suture ligature in. But for the big sacs, I like to put a purse string in. Once you put the purse string in, as you're tying it, you put a forceps in to push anything that could be coming through. You tie it up and you can see exactly what you've done. And then what I would do is I'd cut off this extra. And once you let go, since remember you've pulled it up, once you let go, it disappears. So now you've got your inguinal, you've got your cord structures up, you know they got the vas in it. Now you have to dissect out this plane where you're going to put your mesh. The mesh is going to extend from lateral to the internal ring, over to the pubic tubercle. I put it at least 2 or 3 centimeters rostral so that I get a big surface area for the mesh to grow into. And then you're going to sew it down here to the inguinal ligament, here. So let's get the mesh out. You're going to see in the OR that they're going to give you a piece of mesh that's already cut. Well, that's just no good for this patient. But what if you're doing it on Michael Jordan or one of the basketball players that's 7 feet tall? This may be too small for him. So I don't like the pre-cut mesh. So I take a piece of mesh and I round off the edge that's going to be sewn to the pubis, like this. I round off this edge, but that's all I do now. I don't cut it anymore. And my first stitch is going to be from the mesh to the pubic tubercle. And to do that, you can pull the inguinal ligament either anteriorly, such that you can see or feel the pubic tubercle. This is the inguinal ligament. Or actually, I like to pull it inferiorly, because that shows the pubic tubercle much better. So I'm going to put a stitch in the pubic tubercle, and the way I do it is I put a stitch in the mesh first, then it's easier to go from posterior to anterior when you're putting it in the pubic tubercle. I don't know how well you can see this, but here's, put this down here for now. We'll just hold that there. And then here's, okay, so now we want to sew the mesh in. So we put a stitch through the mesh at this, where you've rounded it off, and then another stitch into pubic tubercle, which is what I'm doing now. It's coming out, bear with me. And it's easier to put the stitch in the pubic tubercle from posterior to anterior than anterior to posterior. And then you bring it out the mesh again, leaving about a ½ centimeter between where your last stitch was. So you can see here, this is the way it looks. So now I'm going to sew it down. And this will hold the mesh in place when we go to finish it. Now I use a Proline for the stitch to the pubic tubercle because it's monofilament, less reaction, and I want that to stay forever because you don't expect the pubic tubercle's periosteum to grow into the mesh. The rest of the repair I use all absorbable mesh. So now what I'm going to do is I'm going to cut the mesh, but I'm going to cut it shorter than I think it should be. So I cut it down. Notice how wide this is. If you make it wider than that, it's too bulky. If you make it narrower than this, see how wide this is. If you make it too wide, it's cumbersome. If you make it too narrow, when you sew this edge to the inguinal ligament, there's no mesh here to allow you to close the mesh lateral to the cord structures. So this is about the right size. And now what we need to do is we need to sew the caudal end of the mesh to the inguinal ligament. And I'm only going to put one stitch in to speed things up. So you're going to have trouble seeing this, but here's the inguinal ligament. I'm going to put one stitch in that. You notice I'm pulling the inguinal ligament caudally. And that exposes the inguinal ligament here. And then you can put it in the right through the mesh. And I'm going to sew that down. I'll point out the fact that the cord now is going to next be brought anterior to the mesh. So here's the cord structures. And now what you have to do is you have to put one of these wings of the mesh under the cord structures. Now you're going to see that I didn't cut it far enough medially, purposely, because I want to tailor this to where I want it. And you can see it's just not cut far enough. So if I cut this a little bit more now, pull this out, now it fits nicely. And you want to take the inguinal ligament that when the hernia sac comes through, it makes the internal ring get bigger. And the cord structures, instead of coming out like this and down, the cord structures do this. And you want to reestablish that thing, that right angle. So now we've done that. Here's the cord structures anterior to the mesh. We're going to sew the mesh to the inguinal ligament up here, but now we have to sew the mesh around the cord. Now some people cut a hole. Well, again, how big a hole do you make it? Depends on how much tissue there is in the cord structures. So I just cut a slit, and then I put a stitch here and here. And I'll tie one that I know is not going to be tight enough, just to give me a basis to work from. Now I need to remind you that when you sew mesh to mesh, if you use an absorbable suture, it won't last. Mesh doesn't grow to mesh. So for this, closing these wings up, you have to use a permanent suture. I'm just going to put one more throw in this. I don't need any more. We cut that. Now, you want to make this slit big enough so you don't occlude the pampiniform plexus, but not so tight, not so loose that another hernia can occur. So most people put a clamp through about like that, and that's pretty good. Now remember, the mesh is going to shrink a little bit, and it's going to stick to the cord structure. So if you have a little hole like this, that's pretty good. And then the rest of the repair now is to sew this down. And we're going to sew it to the inguinal ligament. And I'm only going to put one stitch in down below, but I usually put 2 medial to the internal ring and 2 lateral to the internal ring. So here's the inguinal ligament. We sew this to the edge of the mesh here. Again, I'm only going to put one stitch in here. You notice that I haven't cut the mesh yet. And now I see where I want to be, so now I can cut the mesh here. I usually leave about 1 centimeter to 1.5 centimeters of mesh lateral to the internal ring. So I can cut this up this way. Yeah. And I would normally put another stitch here to solidify that. Okay, now we need to sew the mesh medially and rostrally to support where a direct inguinal hernia would occur, which would be medial and cranial to the cord structures. And again, notice I have not cut the mesh here. I'll cut that after I put this stitch in. Because again, it depends on the anatomy of the patient. If they're short, you need a smaller piece of mesh. If they're large, you need a bigger piece of mesh. So normally here I'll put 2 sutures in between the medial edge of the mesh and as far medially as I can get, often on top of the anterior rectus fascia. So put a stitch in here. And I usually use, again, a mattress suture to get more surface area for the mesh to stick to. Next, we're going to sew the mesh truly cranial. Remember, feet, head, right side, left side. And to do this, I dissect up as far anterior to the transversalis and internal oblique muscle, where this fascia and the fascia of the external oblique meet. And that, in most people, is about this big. And then I just put the mesh in here, like this. So I pushed it up there, put a mesh, stitch through the mesh where I want it. Pull the mesh caudally so I can see where I want to put it through the transversalis fascia, right all the way up here. Put that through the muscle and transversalis fascia, muscle of the internal oblique. And then back out the mesh again. And then when I tie this down, you'll see that I get a huge amount of surface area for the mesh to fix in place. So if I pull the inguinal ligament down, here's where the direct inguinal hernias occur, and you see all this surface area for the mesh to get incorporated. And then I'll put another stitch out here. Why don't I do that to complete it? Again, through the mesh. Pull the mesh tight through the transversalis internal oblique, and then back out again. So you'll see that I use probably a bigger piece of mesh than what many of you have seen when you use that small pre-cut piece that they give you. And now I can cut off any redundant mesh. So now you've got your cord structures anterior to the mesh. We've closed off the internal ring. We've sewn the inferior edge of the mesh to the inguinal ligament. We've sewn the rostral edge of the mesh medially and rostrally, and if you want, you can put a stitch out here. I usually don't because it tucks under the external oblique. Remove your Penrose drain, pull down on the testicle, and now it's time to close the wound. Now that we've done that, and we sew up external oblique aponeurosis, we've closed the internal ring. We've got a huge piece of mesh that covers the area where a direct hernia would occur if it occurs. We've pulled the testicle down. We've protected the vas. We've protected the spermatic artery, the piniform plexus, and hopefully the patient will not get a recurrence. Although with this repair, the recurrence is about 1% to 2%. And one quick other thing, when you go to sew the skin, what I like to do is do a subcuticular closure and then on top of it put Dermabond. Because if you put Dermabond on, you don't have to put a bandage over it. It's immediately waterproof, and they can take a shower that night or the next night and they don't have to change the bandage. But you need to warn them that the Dermabond turns brown and it looks really ugly. And ladies don't like that. And some guys don't either. So that's the way I would fix a hernia.